All right, welcome back, everybody. Our panel is joining the stage with me. We have been setting up this panel basically all day because everyone's been talking about AI and ML, and we're going to dive deep into that. So I think we got everybody here. So our moderators for this group are Dr. David Kim and Dr. Ryan Rivera, who are two assistant professors at Stanford and have had long experience dealing around this topic. So I'm not going to belabor it anymore, and I'll give it away to you guys.
Thank you, Dan. And as you were saying, I think it's a testament to the importance and interest in this topic that virtually every other panel so far today has been an incursion of some kind into the idea of applying machine learning and AI to emergency medicine. We are really delighted to have our three panelists today, all of whom are true leaders in this field. And Ryan and I will briefly introduce you, and then hopefully we can get right into some discussion. So to start, Professor Kurt Langlotz is Professor of Radiology and Biomedical Informatics and the Director of the Interdisciplinary Center for AI in Medicine and Imaging at Stanford. His group focuses on the use of machine learning and deep learning techniques to improve radiographic diagnosis, including both classification of images themselves as well as applications of NLP to radiographic interpretations. Radiology, in which Dr. Langlotz's academic and professional accolades are too numerous to list now, is inarguably one of the domains of medicine in which ML and AI are most advanced today and most likely to significantly alter practice in the near term. Professor Langlotz has founded multiple health IT companies, has over 100 scholarly publications to his name, and in addition to his group's technical work on radiographic diagnosis, has recently published on the ethics of data sharing and the risks of algorithmic bias, both of which are topics we will get into today.
All right. And it's my, oh, go ahead. It's my pleasure to introduce now Dr. Nigam Shah. He's a professor of medicine and biomedical data science at Stanford, associate CIO for data science at Stanford Healthcare. He also leads a large and prolific group that analyzes a lot of different sources of health data, including structural, free text, EHR data, online social networks, molecular biomarkers, really geared towards improving patient-centered diagnosis and prediction. He's really, I think, a leader in the movement to really bring clinical AI and ML from this proof of concept to actual clinical implementation, which is, I think we all believe is so important, including the design deployment of workflows here at Stanford, analysis of cost effectiveness and impacts of specific ML supported policies and practices and things like that. And solving this translational problem really requires not just technical and engineering expertise, but really deep understanding of clinical practice, health systems, economic incentives. It's really multidisciplinary, and Dr. Shah and his group are really well positioned as leaders in this frontier.
Thank you.
And finally, it's my pleasure to introduce Pranav Rajprkar, who is now probably too famous to be considered a rising star anymore in medical AI research. He's currently formatting the final LaTeX equations of his dissertation with Andrew Ng and Percy Liang, after which he is going to start as assistant professor of biomedical informatics at Harvard. So congrats, Pranav, and very well deserved. Pranav has published very high impact research in medical AI with state-of-the-art applications of deep learning to radiographic and electrocardiographic interpretation. And he's already training the next generation of health AI researchers, having founded the AI for Healthcare Bootcamp at Stanford, where he's mentored over 100 students and has taught tens of thousands more through his immensely popular course series on Coursera. Pranav writes for the Dr. Penguin Research Newsletter and co-hosts the AI Health podcast. And finally, I'll mention that Pranav is also a superb collaborator with whom I've had the pleasure of working recently on a project in which we're developing models for physiologic monitor data in the ED to deliver better care for ED patients. And that leads into our panel. That's going to start off.
All right. So I think we'll move right ahead into our first question. And as you all know, this is an emergency medicine focused conference here. And this is for the entire panel. All of you are prolific researchers with a wide variety of projects under your belt and underway. What would you say is the machine learning or AI project of yours that has the greatest potential to affect the practice of emergency medicine? I mean, this can be a present project, a past project, or even something that you're going to be working on in the future if you want to give us a little peek into what you've got in the pipeline. And maybe let's have Kurt start with this one, and then we'll go to Pranav and Dr. Shah.
Sure. So thank you. It's a pleasure to be here today with you and to talk a little more about emergency medicine and AI. And I guess I'd use an example not from my lab, but from our center, where we have one laboratory, Greg Zaharchuk's lab, and also Shreyas Vasanawala and others who are looking at ways to reconstruct images. So this is something that might go inside a device. So I think of the emergency department as one of the key places where we do a lot of point of care imaging. So you can imagine that ultrasound device, which maybe doesn't perform quite as well as the big machines we have in the radiology department in the past, but you could imagine improving that device so that the images were of higher quality. You can imagine getting assistance on when the positioning of the device is optimal to image a particular abnormality or body part. So I think you're going to start to see those kinds of applications embedded in devices, and that'll be one of the areas where the emergency department will see AI, really not as AI, but just as better, more capable imaging devices.
Maybe I can add. So hey, thanks for having me here. I will say that one application I'm very excited about is ECGs. When I started working in this space, one of the first things I learned about the ECGs is, although automated interpretation of ECGs has been around for decades, clinicians in training are taught not to trust that decision too much. I think the transition that's happened over the past few years is that with deep learning algorithms, we're able to do a lot of diagnostic tasks as well as cardiologists can. And it's been shown not just in a 12 lead setting, but also in a single lead setting with monitors that go outside the clinic, like iRhythm's CO patch. But I think what's really exciting to me about the ECG is going beyond the tasks that are currently part of clinical practice. There is a lot of opportunity to use the data to be able to do predictive tasks. And just as an example here, the CHA2DS2-VASc score is used a lot in the emergency setting. And it's based on a bunch of heuristics, which are very human interpretable. And that's great for making a lot of decisions. But there's a lot we're missing in the data as well. And I think being able to incorporate ECGs to be able to perform predictive tasks, like there's a recent work that showed one can do 1-year mortality based on ECGs. And of course, that opens up a variety of applications, and it opens up risks as well. But being able to do prediction in the near term as well is going to be an incredible opportunity, and one I'm very excited about. And of course, as David mentioned earlier, something we're working on together to try and build models for.
My work is not related to the ED, and the most relevant thing that's related to that is mechanisms to keep people out of EDs. So one of the things that we've been investigating is, can we predict who is going to get medically expensive? We did that in 2016-17 timeframe. Next up is, can we guess what is the driver of that expense? And if that happens to be an ED visit, there are now people out there, for example, services that are called ED, not prevention, but they call them redirection services, as in a nursing team that would intercept and have a conversation with the patient to see that can that particular incident be handled outside of an ED. And health insurance companies are actually quite interested in identifying those individuals who are on their way to the ED or likely to get there in the next month, but who shouldn't be there in the first place. Mm-hmm. So, I'm sure most of you in your careers have met patients where you would wonder, why are they coming to me at this point? It's not an emergency. It's not a broken leg. You could have taken care of your diabetes better, and I don't need to see you in this setting. Those are the kinds of workflow issues where can we deliver upstream care such that the use of the emergency department is focused on true emergencies, things that cannot be predicted, like an appendicitis or a broken leg, rather than have chronic care delivered in the ED setting.
Yeah. No, and I would say that's very relevant to emergency medicine. I think some of our earlier speakers talked about how the care process starts when the patient contemplates care and what they might need and where they might receive it. And I think emergency medicine docs and emergency departments in general are very invested in making sure that patients are able to go to the right place and not necessarily come to the ED when they don't need it. But yeah, thanks for sharing very practical projects. And Kurt, definitely let me know when that will help me get better images. I'd be very excited to use that in the ED.
And a range of very interesting responses, and I like contemplating the idea that our specialty might end up by default to encompass everything that isn't adequately predicted by machine learning, which is a good job security for the humans in the business. And some of you have addressed this already in your answers, but we'd like to get into this. So having mentioned these potential applications, Kurt mentioned device embedded applications to improve imaging technique. Pranav talked about novel applications of ECG interpretation for near and long-term predictions. Nigam talked about implementation and workflows. This is a very broad scope of projects. What are the barriers in your views on actually seeing these technologies and ideas incorporated into practice, and that can be interpreted however you like, from technical to conceptual to economic?
Yeah, I have two thoughts about that. One, I think we have an advantage in imaging in that we have DICOM, which is a standard that's very widely adopted. So we start with raw data, if you will, for the AI algorithm to process that's in a standard form. And that makes that end of the problem much easier. I think when you start going beyond that to other forms of data, there is a lot of work is needed on the provenance of the data. Blood pressure could be sitting, standing, is the patient in pain, and across the board. Some of it's in the form of text, which is not as precise and the like. So that's kind of one end, the input level challenge. But I think what we share with other forms of data that imaging shares has to do with the output side. So there's a great industry out there, over 100 companies working on radiology AI, for example. And there are probably a couple dozen vendors that sell PAC systems that view those images. How are those going to connect, right? What's the right way to present the information to the radiologist? Whether it's part of the report, whether it's some kind of a heat map or overlay, whether it's some perhaps text advice, and standardizing those methods and building I think Topher Sharp mentioned earlier today, the infrastructure that we need, where the algorithm can sit, can accept data from throughout the health system, execute, and then inject a result back into the proper workflow. That's a complicated thing, and those kinds of processes are still being worked out. I think Stanford were steps ahead, but I think everyone's looking at that right now.
I agree with that, and I think there are lots of different challenges and different categories of challenges. There's a set of challenges around usability and safety, and who's using the outputs of these algorithms. And I won't talk much about that because Nigam has written extended reviews on that and probably will be able to give a better summary. So I'll talk about the technical challenges a little bit here. I think one of them is that when we are dealing with algorithms that try to do what clinicians do, we're often focused on a very small subset of the tasks that is not truly reflective of the full scope of the decision-making or the diagnosis that a clinician's doing in their setting. And I think that's a transition which is needed. And a lot of that transition has to do with the fact that we aren't building algorithms that can really take advantage of small amounts of data. We really need these large data sets. I think that's sort of driving into the second challenge here, which is data sets are few and they're overused. A small amount of them are sort of driving most of the innovation. And I think being very careful and very thoughtful about the kinds of data sets that we can start collecting now, such that they become great data sets for machine learning 5 years from now, I think would advance the field quite a bit. And finally, I think we need more studies that are thinking not just from a retrospective angle, how does this AI compare to radiologists or to clinicians? We've all seen those kind of studies be successful, but really look at prospectively, how are these algorithms performing in a randomized control trial? How are they performing when they're given to clinicians as part of their workflows? And the state of the industry here is actually fairly sad, in that there was a recent review that found that a lot of FDA approved and FDA cleared algorithms are actually demonstrating value just on retrospective data. So we have all these algorithms out there that have been approved and that have been cleared. And I'm personally fearful that we're going to have one of these algorithms that's going to be unsafe for people to use. And that's going to set the community behind several years, such that we're unable to get truly valuable algorithms out to the community. So that's one thing I certainly think about, and many others in the community are also actively thinking about.
Yeah. So the biggest challenge that I see is fragmentation. There's fragmentation of data, there's fragmentation of care, and there's fragmentation of specialists. I mean, my dad's a surgeon, and we often like, when are we going to get the left foot surgeon and the right foot surgeon? I mean, we're kind of there already. And what's happened is that in the process of industrializing healthcare, we've turned what is an inherently case-based process into a task-based process. And what happens is that now we have, upwards of 15, 20 humans involved in the care of one case, and each one part of a not yet fully fleshed out conveyor belt on which the patient care journey happens. And no one sees the whole conveyor belt. No one sees where the gaps are. And it's up to the patient to jump from one gap, one end to the other. And so that leads to fragmentation of the delivery, of the data, the modalities, the handoffs. That I see as the biggest challenge for bringing AI and machine learning into healthcare, because we're localizing the AI solutions into extremely narrow and local minima in the conveyor belt or someone's health journey.
Thank you for those responses. So, for some of these problems, you can imagine, especially on the technical side, you can imagine what form the solutions would take. For these fragmentation, implementation difficulties, it seems to be more a matter of getting the incentives right, for producing data commons, for providing resources for for the coordination of what Nigam, you described very well as these excessively discretized systems whose interconnections are neglected. What's needed to do that? How do we incentivize solutions to these problems?
I think the biggest incentive is some form of accountability and capitation. It's gradually happening. There are already markets in which the deal is, here's Nigam, here's $25,000, keep him healthy, happy, and alive. All three things. Because if he dies, you get no money next year. If the person's unhappy, then you get a penalty. And if they're unhealthy, then you bear all the cost beyond what's paid for from the premiums. So to the extent that we see technology enabling such alignment is the extent to which I think data and algorithms writ large, call them machine learning, call them AI, will help in improving healthcare. And in part of that integration, there's also migration of care sites from high acuity, high intensity settings into the patient's homes and lower acuity settings. And I think, again, technology that enables that is going to be technology that maintains the care continuum as opposed to increased fragmentation.
Yeah,
and
fascinating. I think that.
Just expanding on that, on Nigam's point. So I think what he's identifying is many things that are problems with the health system as a whole, which do affect AI. But I think one of the ways that AI might catalyze some change there is that we need these very large electronic data sets, and the same kind of data needs that we have to build our algorithms are the data needs that a health system or a health enterprise needs to build the measures where it can actually assess the quality of care that it's delivering and perhaps understand the risks that it might be taking on in a capitated environment, those sorts of things. So those are two common pathways. When I'm building an AI algorithm to satisfy a clinical need, those are almost always clinical needs that will be true either in a capitated environment or in a fee-for-service environment. It has to do with improving the efficiency of care. It may have to do with improving the quality of care, or both. And so, I mean, I think that many of the machine learning algorithms that we'll be talking about and are talking about will improve the level of care either way as we make this shift to more value-based care.
So just to point to a very concrete example, I mean, Pranav talked about reading EKGs, for example. You can take that a step ahead and say, I'm going to train an algorithm that, given a single lead EKG, is going to take a guess at the person's ejection fraction. And it's not going to be perfect, but I can guess it, within 5 to 10% error rate. Now I can, if it works, if we could build such an algorithm, now that enables a whole new paradigm of care where a person with congestive heart failure could be monitored by a wrist-worn device that's monitoring their ejection fraction with a certain amount of anticipated error, but allowing you to spot their decompensation way early, then they land up in the ED in front of you. And so that would align the incentives and the technology to keep people healthy in their homes. That's something that's possible today, given current incentives and current machine learning. And we'll have to take these kinds of small steps so that we gradually get to a state of affairs where everything is lined up. I mean, it's not going to happen overnight with a flip of a switch.
Mm-hmm. I'll just add to that one of the other incentive building changes that's happening is CMS approving the reimbursement of AI algorithms. So currently we have two such reimbursements, one of them for digital diagnostics tool for diabetic retinopathy referral, and getting those out to the Walmarts and saying, okay, here's a patient with referable diabetic retinopathy. Let's get them to see a specialist, and that can be reimbursed. And VizAI's head CT stroke detection, which can also get reimbursed. So I think as companies are navigating this flow from getting FDA approval to actually getting CMS reimbursed, I think we will see a lot more of an incentive for hospitals to pick up these technologies, because really FDA approval or clearance is not the end game. It's the reimbursement that's really going to be driving hospital adoption for these technologies, unless it's getting to consumers. So some of the companies are going down the route of let's sell directly to doctors. I guess in the ED setting, a company like Echo is able to sell directly to doctors, say, hey, we'll provide you a digital stethoscope with some AI, and that might help you. And for some doctors, that's okay. They'll pick it up, but it's not a institutional decision at that point. So I think some of these transitions can happen through better reimbursement pathways for these companies to take.
I think this is very fascinating. I mean, I have a public health and policy background, and I know the public health community has often lamented the fact that our health system is not really structured in a way to economically incentivize preventative care and things like that. And I'll say from this conversation, it's really stood out to me that AI and ML by its nature very often is going to help you know when something is going to happen in the future. And our healthcare system is designed to pay for and treat care that is happening right in this moment, that is an immediate emergency. And so it's an interesting alignment between kind of the AI and ML communities and the interest of public health in terms of how we restructure our healthcare system.
Mm-hmm.
So one of the other things we wanted to dive into a little bit, talking about barriers to implementation of AI and machine learning in healthcare, is specifically the problem of interpretability. We've struggled getting physicians to follow clinical pathways and treatment protocols, even when presented explicitly with large amounts of justifying data and studies. Now, while not all AI and ML is of a nature where it's uninterpretable, Do you think that there is going to be a barrier in the future if we're presenting physicians and patients with algorithms for which the explanation is not clear, for which they can't point to a very obvious physiologic mechanism behind the recommendation? And if so, how do we navigate that?
So, the notion of interpretability is very important. These systems are going to be working in tandem with humans, but also just want to put it in context that there are many things that we do in healthcare that we don't understand. So how does a Tylenol work? We don't know, but we trust that it works because there's been a clinical trial that shows that, it relieves pain or whatever it is. You could take that to a number of different interventions, medications, diagnostic technologies. And so it's more about trust. It's more about, do we have the right information, the right data that shows us that if we use this algorithm, it's going to help us. So that's kind of number one, is that really I like to think about more about trust than about explainability. On the other hand, I really do think that's an incredibly rich area for work. The things that we use in imaging today, for example, heat maps, that's a very crude and often not very accurate way of describing how well an algorithm is working. But I mean, I'll tell you that back when I trained in AI, it was all about symbolic reasoning and the kinds of reasoning that is very easy for humans to understand. If this, then that. And I think you're starting to see research where you can combine those, or at least overlay some kind of a symbolic reasoning approach or a Bayesian network or something like that would be more explainable onto the more opaque, millions of parameters neural network approaches, which provide good answers but can't explain themselves as well.
Thank you for those responses. And along those lines, I've often wondered, are we imposing a higher standard on ML and AI methods than on conventional statistical methods? I mean, I would imagine that most clinicians don't know and don't care that the decision instruments they're using have scoring systems that are integer rounded logistic regression coefficients, and that's just taken for granted. So I suspect, as I think some of you alluded to, that a lot of it is going to be more a cultural and sociological process than necessarily a technical one in terms of providing better explanations. But along the lines of explanations, it seems like there's a divergence happening between the aspects of machine learning in healthcare and clinical applications. And it was mentioned in that to get published, you want to be doing something edge, and to influence care, you want to be doing something that's been established for a decade in the research. Do you envision that these are going to become very separate tracks in health AI research? Is that appropriate? And what is the potential of clinical applications to feed back into novel hypotheses and actual new science?
Maybe I can start off there. So I think there is a little bit of a distinction between the scientific applications and clinical applications that we're seeing. And let's take an example like the interpretation of ECGs. And so, for example, one of the things that's been going on in terms of interpretation of ECGs to get new scientific insights is, well, can I tell different factors like sex or age or mortality from the ECG? Not that you would ever need to get sex from the ECG, just as you wouldn't need to get sex from from retinal fundus photos, but that's something that's been done. And then going back to the question of interpretability, you might wonder, well, why is this? I want to know exactly what the biological mechanism might be that might explain why there's this correlation that's been found. And then I would want to understand or lay out a hypothesis that I can then test experimentally. And that's something we're seeing going on in the let's say, pathology or radiology, where we're seeing sort of these correlations that are being found that can be used to then decide, okay, is this patient the right candidate for this particular trial? Because I'm able to look at their pre-treatment whole slide image, and I'm able to say, okay, this is a patient that will likely respond to this drug. One of the nice things about, let's take drug development as one of the scientific applications, is that in terms of regulatory standards that are needed, it's a lot lower than when looking at clinical applications. So one of the things that's that I've found to be going on in industry is a lot of deployments are happening in collaboration with pharma first to say evaluate clinical trial endpoints, both in radiology and pathology. And then while FDA approval processes are going on, that's been the focus. And then there's a transition in focus after FDA approval. So that's a pathway which several companies are taking, where I guess there's a leaning towards going after a scientific application first and then transitioning into a clinical application.
And I don't really see necessarily a trade-off between foundational research and clinical applications. In fact, one of the main motivating factors behind the StEMI Center, this interdisciplinary center, is that if you identify real clinical problems that need solving and you define them well and you have an appropriate data set that will help you solve that problem, that's going to lead to the need for foundational some advances in the basic science in order to solve those problems. So there's a nice kind of interplay between the clinical need and the foundational science, and that's why these interdisciplinary teams are so important when trying to solve these problems.
It's been a great discussion so far. I'm just going to break in really quickly to bring up some of the audience questions we came in here. I'll try to combine a couple of them. So one of the questions was around where this panel kind of sees truly scalable AI and ML impacting healthcare. Is that going to come from this group of panel who are primarily working in academia, or is it going to come from private industry in the big tech companies like Google, Amazon, Apple? And maybe an example of that would be the Stanford Heart Study looking at predicting AFib and how we're now sending patients to the hospital. Is that going to be the purview of those large companies, or is it going to be, when we get to scalable, more an academic center like Stanford?
So
go ahead,
Kirk.
I was just going to say, if you look across the different types of, where might this come from? Small companies, big companies, academics, big integrated delivery systems. You look at what academic institutions have. We have clinical expertise. We have computer science expertise. We have data. We have a healthcare enterprise where we can test the things that we build. So we really are set up to be an innovation center in this area, no question about it. But I think it is interesting to think about in industry, because ultimately, if we want to affect not just what we do at Stanford and other places like it, but across the country and the world, you need industry to productize, sell and distribute and so on, disseminate. And I think that, one of the most interesting things that happened, and it happened just this week, is that Microsoft just bought Nuance, when Nuance being, of course, very heavily into the health market, and they were very explicit about the fact that that acquisition was in part due to their desire to get into the health market. And that's really, to me, interesting, because we've seen a lot of interest and some dipping the toe in from the cloud type vendors trying to get into the health market. And this seems to be, to me, the first really genuine, serious investment, and one that's likely to play out positively for the companies involved.
Yeah, so I would say it's important to take an ecosystem lens to this. So I'm going to use an analogy of the cell phone. The fundamental tech underlying cellular telephony was invented at Bell Labs in New Jersey. But if you ask a person off the street right now, as in, who brought cell phones to you? It's highly unlikely anybody's going to say Bell Labs. They might not even know about Bell Labs anymore, right? And then so there's fundamental invention, and that could happen anywhere. It could happen in universities, it could happen in the R&D departments of companies and so on. And then there are sort of enabler technologies on which things piggyback, like availability of smartphones, availability of the Android operating system that made cell phones so cheap that 3 billion people that don't live in the US can afford them. So something analogous like that has to happen for massive adoption of pervasive computing. And I try to stay away from AI and machine learning because that puts a very narrow lens onto it. I mean, think of a cheap sensor, a data stream, and an algorithm. Those three things taken together help you do medicine better and cheaper. And where will it scale? It's going to be an ecosystem lens. And my guess is that that ecosystem is going to be driven by payment systems, as in insurance in the US and governments elsewhere.
I'll add to that I feel like consumer healthcare will probably be dominated by these large companies. An example of this is, I think for PPG analysis, we now have Apple, Samsung that are either deploying or have already deployed these systems, and these have been used by tens of millions of people already. So in a way, this the scalable AI and ML happening in healthcare has been achieved. I think there are a lot of things that these actors won't do. And I think largely, I think about it as anything that affects less than 1% of the population will never be something that Apple or Google or Amazon ever take. So if we're focusing on sick patient populations, these are not the actors who are going to be doing it. I think the trouble with classic healthcare giants is whether they're going to be able to attract the computer science talent that's necessary to do to build these scalable applications, because building these algorithms is one thing and deploying them is an entirely other beast, which requires expertise, not only in machine learning, it requires expertise in software engineering, on medical devices, hardware, implementation, delivery. And these are a lot of things that healthcare systems may not be able to navigate by themselves without partnerships. So I think that there is an opportunity for startups to be able to take some of these spaces and grow with time and really get to the scalable AI and machine learning for maybe that 1% of the population or smaller.
Yeah, and I'll sort of build off of that. I mean, most people here, I would imagine, have some sort of healthcare background. And when we think of healthcare, you don't just think of emergency medicine. I mean, you think of the primary care, you think of the ICU docs, you think of the surgeons and the orthopods and the obstetricians and so on. And it's a whole suite of specialties that cares and provides healthcare. Something analogous is going to happen for the adoption of pervasive computing in our industry. It's not going to be just the big tech players. It's not going to be just the startups. We're going to need ethnographers. We're going to need business people, hardware people, software people. So the model is a place to start, but I think there's a classic paper from Google showing that your model is a bit, and then there's like a whole set of things around it to make it work. And I think we need to focus on that whole set of things in healthcare.
Well, great. This has been a wonderful conversation. Maybe Ryan and Dave, you can bring us home.
Yeah, no, I think this is fantastic, and it was great to hear from all of you, not just about the innovations that you're working on now, but also the tremendous work that you're doing on the surrounding systems that will help make this more implementable. And I hope for our listeners out there, this gives you a little bit of a better sense about kind of what's coming next and what you can do to prepare yourself. I mean, I have been involved in this topic only for the last several years, but I remember back at HIMSS probably 4 or 5 years ago, I was really struck by a presentation from Eric Schmidt where he told a room of very healthcare technology focused individuals that the big thing coming was AI in healthcare, and it was going to hit them like a freight train, and none of them were ready and none of them were prepared. And that stuck with me for quite some time. So I hope presentations like this and all of the work that you're doing are going to help us be a little bit more prepared to be effective clinicians in that future environment.
All right, Great. Thank you guys all so much. We'll be back in about 5 more minutes for our last panel.